of guests. So, all right, we've got the recording going. So I'll begin with the welcome and introduction. Hello, everyone. Welcome back to our weekly DBMI seminar series after a couple weeks away. I hope everyone had a great time at AMIA, had a good town hall session a few weeks ago, but now we are actually returning to our special seminar series towards diversity, equity, and inclusion in informatics, healthcare, and society. And this week we are incredibly lucky to have a very wonderful guest, Dr. Julia Iyasere, MD, MBA. She is the executive director of the Dalio Center for Health Justice at New York Presbyterian. In this role, she leads the center's efforts to address longstanding health inequities due to race, socioeconomic differences, limited access to care, and other complex factors that impact the well-being of our communities. Dr. Iyasere attended Yale University for her bachelor's in biology and Columbia University for her MD, MBA. After completing her residency in internal medicine at Columbia, Dr. Iyasere joined the Division of General Medicine at Columbia in 2012. Prior to her current role, Dr. Iyasere was the Associate Chief Medical Officer for Service Lines and the Co-Director of the Care Team Office at NYP. An Assistant Professor of Medicine, Dr. Iyasere continues to see patients as an internist in the section for hospital medicine at Columbia. And with that, I will let you take it away. Thank you so much.
Great, and thank you for having me, everyone. I'm happy to talk about this. I admit I have a habit of not leaving enough time for questions, so I'm keeping myself to time because there's always a lot of questions, particularly in this space. So hopefully I keep true to my word and I leave at least 15 minutes. If I don't, however, please feel free just to interrupt me. This is a relatively small group, so if you have questions as I'm going along, just raise your hand. I do keep an eye out for questions as we go, or drop them into the chat, simply because the goal of this talk today is really about engaging all of you in some of the work that we do, and in really making sure that when we think about health equity, not that we all have to think about it the same way, but it would be great if we had similar definitions for how we approach the use of data, that we think about a sort of principled approach to not only the collection of the data, but then the use of that data. So today I'm going to talk about a little bit about how we think about data in the Dalio Center, very quickly around the social determinants of health, then a bit about how the social determinants of health can be used both at the population level and at the interpersonal, so patient level. I'll talk through a couple of the things that we do at New York Presbyterian to improve the collection of data, as well as how we validate some of that data. So our demographic data, how do we make sure it's any good? And then I'll highlight how we are using that. I am not sharing any NYP data today, although I assure you in the background of all of the things I talk about, we have existing databases that really are helping to advance our work in real time. So I will reference some of those things. If you have a CWID and a password, some of them are accessible, so I can direct you to where they would live. They're on our infonet on NYP, at NYP. And then lastly, I'll close with just a couple of the other things that the Dalio Center does. So although I spend a lot of time talking about data, more so than I ever thought I would, that is actually just one part of the Dalio Center. And so I'll just quickly highlight some of the other things that we have underway, and you can kind of see how it all fits together. So with that, I'll go ahead and share my screen and let's get started. So just to start, I have no disclosures. No one other than NYP pays me to do any of this work. So maybe someday I'll have something to put here, but for right now, I do not. So just to set the stage, and many of you may have seen this before, I'm not going to spend a lot of time on it, but it's just to really level set and make sure that we're using the same definitions when we're talking about equality, equity, and justice. We thought about the terminology justice really deliberately and Health equity, in this case, customization of the interventions to equalize the outcomes, is central to health justice. So we do think about customizing interventions, customizing the tools. In this sort of picture, it's so that everyone can achieve their optimal health or see the other side of the fence. But one of the reasons we think about justice is that then you sort of take a step back and ask, why is there a barrier to your optimal health? And is there the potential that we can mitigate that barrier? Can we knock down the fence? That is a lot of like the career defining work. That's work that takes decades. I am very realistic about the time scale of some of these interventions. So, future world, we see a world where there are no fences. But until we get there, customization of the tools, in this case, the step stools that people are on, is so integral to the work and is part of what we do. So when I'm talking about data collection, I'm talking about the types of data that we collect. It's all because we each live different experiences. We live in different areas, we have different exposures, and that all leads to different outcomes. So our job as healthcare professionals, as part of the healthcare system, is to identify what is the outcome that we want to achieve and how do we help people get there. So equity and justice are core to what I do, and it's actually, I was recently promoted to, I haven't changed my bio, so Courtney, do not worry, I didn't send it to you. I was recently promoted to Senior Vice President for Health Justice and Equity for New York Presbyterian. And we include both, thank you, we include both justice and equity in that title because that's the work together. It's both of those things. So just to kind of level set as we're talking about equity and justice. This is the Dalio Center. Our overarching goal is to help identify and eliminate health inequity. It's pretty broad, a lot of things to do there. You could pretty much boil the ocean, but we divide our work into the 4 pillars that you see on the left. Foundation is data and infrastructure. Core to the work is all of our clinical work and our community linkages, and then the community work. So it's in the hospital, outside the hospital, and what connects the two together. We are an academic healthcare center twice over, so research and supporting the research of our faculty is quite important to us, as well as training and educating future healthcare leaders in the importance of health equity and health justice so that we don't silo this work. That's the worst thing that I could do, is to make it othered and to say we only do it within the Dalio Center. And it's why I love giving these talks, because we all own this work. We all own health equity. We all own health justice. If we don't, it's not feasible to actually attain the health outcomes that we all want to see. So life expectancy, this is New York City 2019 data, I think. In these 2 areas, this is Brownsville and Brooklyn, and then the Upper West Side, there's a 10-year gap in life expectancy at birth. And I used to walk people through a whole host of slides to say, well, what do we think is the reason behind this? What are the differences in these 2 areas of New York? But I will just tell you, there are differences in education, in access to education. There are differences in access to food, the presence or absence of healthy eating and green spaces. There are a lot of differences between these 2 areas, and these are the differences that we identify. These are the gaps, the differences in opportunity that people have, which lead to this gap in overall mortality. And these become the social determinants of health. The CDC defines them as the areas in which we learn, grow, age. I always say that it's where if we do our work right, it's where people thrive. But one of the things that we've sort of changed over the last year is that we define them, and I will use this terminology interchangeably. It will be in my slides in one way and the other. I'm just telling you now. The social determinants. Determinants tends to mean that it is predetermined and that it's not something that we can influence or change. So a lot of people have sort of started to say, well, can we call these the social influencers of health or the social drivers of health? Because it means that we can influence them. It means that this isn't predetermined for your life. It means that if we do what I said before, our job right, we're able to help people to thrive. So you will see this changing terminology. It's become more in fashion to say the social influencers of health, social drivers of health, rather than social determinants. But because SDOH is such a buzzword, I do use it most of the time. But just from note in the background, it's a lot of the data that we collect, all of these social drivers. The goal is to identify what can we do as a healthcare system to leverage or intervene so that we have the desired outcome we're trying to achieve. So as I said, the CDC defines them as where we're born, grow, live, work, and age, and including healthcare, they are what make up your optimal health. Healthcare is about 20% of this. The other 80% is where we're figuring out how do we work outside of the traditional boundaries of the healthcare system so that together we are, as a whole, more powerful than in any of our individual parts. So you'll see, and I'm sure you've already seen this, that people are using the social determinants of health, generally at a population level, to evaluate risk. So this is the CDC's Social Vulnerability Index, the SVI, and it looks at what are the various areas. This is across the country, but this is a map of New York City. What is an estimation of risk of the people that live in these specific areas? And, originally the SVI was created to identify, well, what's the risk of a specific neighborhood if there is a mass casualty event, if there is a earthquake, if there are these like large scale crises. And it is always important when you're thinking about these indices, what was their original intent? Why were they built? Because then many of the inputs, the variables, are then dependent on that. So a couple of the caveats to things like the SVI is that it looks at prison systems as the same as it does dormitories, because you're looking at the number of people in a concentrated area. But things like the Social Vulnerability Index are now used in US News and World Report to adjust some of the outcomes based on the risk of an area. So both from the CDC as well as from other, this is the Area Deprivation Index, the ADI. It's the use of some of the social determinants of health data to guide interventions and strategy. You can see this widely used across not only regulatory reporting, but then also within systems, people are trying to assess risk level. And I think it's really helpful to understand not only the level at which the data is being collected, but and I'll talk about it in a couple of slides, of what's then the intervention. So both the population level data is really important, but I'm going to make a case that the patient level data is equally as integral to advancing health equity. So there's numerous papers out there that look at the relationship of ADI, which is similar to the SVI, although it's slightly different inputs, at readmission rates. And again, you can see here that the higher the risk or the estimated risk of an area, the higher the readmission is for someone. So this is what are the social determinants of health that are at risk? So it's food, it's housing, it's transportation. And does that have a correlation or a link to readmissions from a hospital? This data is then further broken apart by different types of admissions. So patients with pneumonias, patients with heart failure. Again, that same trend holds true, that those from more vulnerable areas have an increased risk of being readmitted to our hospital. And I think this makes sense when you try to say, well, does this pass my little sniff test of why is this happening? Well, I told you that a lot of these areas, when we're looking at assessing risk, we're looking at access to transportation, access to the healthcare system, access to healthy food, access to pharmacies. So you can understand that areas that don't have that opportunity, when we discharge patients back to an area that doesn't have access readily to primary care, well, the chance that that patient is going to come back is higher. And that is borne out in the data. At the population level, and then I'll show you some slides later that it's also borne out at the individual level of risk as well. So I'd like people to think about this of, can we use population level data at the individual level? So the last two and many other papers look at an assessment of risk for a population and then use that as guiding to create interventions at the system level. Well, there's been a sort of a little bit of a push in this space to use population level risk at the individual level. And although I think it's helpful to understand population level data, I think it's also very important that we understand someone's individual risk. And I'm going to show you why. So in this area, this is the zip code 11205. And this is data from 2010. And if we look at the population level data here, we can identify that this as a zip code, this is a poverty level, but within that zip code, we have differential levels. So if someone is at 41% versus 5%, we wouldn't want to offer the same interventions to those two individuals. They have two completely different levels of risk. Well, also the data that matters in terms of the age of it. So if we go back in time, and now we're looking at something which is 10 years earlier, well, the entire zip code now is at more risk than it is now. So one of the things that you see in a lot of this SVI work or the ADI work is that the data is always lagged. So what you're looking at currently is not actually what you are seeing in some of these risk assessments. But then there's also individual level characteristics that are very important to tease out. And it's one of the reasons why I generally make the argument that population level data is very important, but it should be paired with individual level data. And it's a lot of what we do within the Dalio Center is to say, we are going to look at these population level characteristics, but then we're going to do the work to ask our patients about their actual risk for food, for housing, for transportation, for utilities, because the differences in this case do matter. There's a lot of literature out there connecting the social determinants of health with both outcomes as well as readmissions. Food is probably the most, food and housing are the most, there's the most literature to support the mitigation of food insecurity and housing insecurity for the healthcare system. But the papers go on and on and on. So I'm not going to belabor the point here to show that it is important that we identify individual level risk. I will, however, call out some data. This is about homelessness, looking at individual level risk. And I'm going to just flash ahead to say that this is work that's being done at New York Presbyterian. So this is Dr. Monica Safford at the Cornell Center for Health Equity, looking at individual social determinants of health risk and the additive effect of SDOH on coronary heart disease, both fatal and non-fatal, showing that there is a graded dose response. So the more social determinants of health that someone says are at risk, the more their risk for fatal and non-fatal MI. So all of this taken together brings us to the point where we are in the Dalio Center that says we have to do this work. We have to identify the social determinants of health. We have to ask our patients these questions. And then we have to do the hard work to pair our patients with the actual community-based organizations that can help to close that gap. We do recognize that as a healthcare system, where our strength is in the provision of health care. So we can't get too far outside the boundaries of the healthcare, but we can create partnerships and collaborations that help us, again, to become more than just the 20% that is the overall health. We can actually create partnerships to be all of the 100%. Because we're all doing this work together to advance health equity and to achieve optimal health outcomes. So we do this at NYP and at any other nonprofit that has to do a community health needs assessment. We do population level screening every 3 years. We actually just closed on our last community health needs assessment. And from that, we create population level interventions. So population to population, individual to individual. So we create community service plans that say, what are we doing for this area? What kind of interventions are we making that are broad-based, that are for an entire neighborhood? But then we also are creating the workflows to identify individual level risk so that we can match patient to patient. So if a specific patient has a need in food, housing, utilities, we match them with a community-based organization that can meet that need. You will see a lot of this coming in the next year. It's now a new CMS and Joint Commission requirement. Thankfully, we started this earlier this year, so we're a little bit further ahead. But this is where I think everyone in the community around health equity and health systems is going, is the identification of social determinants of health. But it begs the question then of how do we use that data? How do we use the social determinants of health? How do we use things like the demographic data that we collect? How do we use that in a way that is responsible? So I'm going to take you back to, so that's a little bit of like background, what we're doing in terms of social determinants of health as a community in health equity, and then why it's important for us to do that work. Because if you remember that first map, when we're looking at two individuals that come from two vastly differentially resourced areas of New York City, we have to understand the lived experience of those individuals so that we can customize the health care that they receive. So we can make sure that we are creating those step stools so that people can see over the fence, not just saying, well, we'll give you something, but you may still be seeing the grain of the wood of the fence. So back to the Dalio Center and our 4 pillars. In data and infrastructure, we spent a lot of time last year collecting race, ethnicity, language, sexual orientation, and gender identity data. And I'm going to talk through some elements of that data as well as some of the challenges in its use and where we're going with that now. Also, we launched social determinants of health screening in our emergency departments this last year. We're going live with inpatient screening next year. And again, it's the data collection of it, but then also it's the use of that data. So what do we recommend for how to use the data? What are the challenges in the use of the data? And that's where we get to quality and outcome measurement. So the first 2 bullets are all about data collection. Then we start to get into, well, how do we take the data that we've collected and use it in a responsible way? And so I'll talk a little bit about our quality and outcome measurement, some of the principles that we've developed in the Dalio Center for the use of this data. And I'm not going to talk about it here, but some of the other work that we're engaged in as a New York Presbyterian is with our city on, so it's called CIRCA. It's a coalition to end racism and clinical algorithms. And so there's a growing, I think, body of work to suggest that, well, not to suggest, to support that we tend to use race as a, not only as a proxy indicator, but in many cases, simply it's been added to things it has no business being in. And so and that no one can actually understand why it was included. So part of our work is to unpack all of that and to understand why were things created in the way they were. What was the actual indicator that someone was trying to get to, and how can we sort of peel back and take out a lot of these proxy indicators, and how can we actually just do the hard work to identify what is the biological basis of whatever you're trying to identify, and stop using sort of socioeconomic status or other proxy indicators instead of the true, like the actual variable that we're trying to get to. That's the work of like that's a lot of work and a lot of effort that's being done there. So we launched We Ask Because We Care about race, ethnicity, and language. And overall, we improved our organization's collection of race, ethnicity, and language by over 20% over the last year. We then did subsequent census validations on that data. So this is self-identified data. And we look at the area in which our hospital is. So each of our 10 hospitals, we take disaggregated data and we look at census matches. We know that the 2020 census was not the best. There are a lot of reasons that census was not deemed to be ideal. But at least we do some rough analyses of, is the data that we have in our hospital what we would expect based on the demographics of the area in which our hospital is, plus a bit of quaternary referral. So with that, we've actually seen pretty excellent matches of the data. And as of right now, if you want to see a lot of our data, we just published our health equity report. It should be on our external website today. So you can see a number of analyses of the demographics of our hospital in comparison to the city, and then in comparison to our catchment area. We also then published internally published numbers of guiding principles for how to use this data and how to really think about the collection of the data, how to make sure that the data that you're using is a representative sample. And we've given a number of our own guiding principles around that. It's never going to be perfect. I don't think we expect it to be, but I think, again, we can all sort of agree on some guiding principles for the use and sort of the kind of moral and ethical use of this data going forward. So these are all on our internal websites for people to download, and as they're starting to think about data collection, as they're starting to think about data validation. And then we created a whole host of dashboards. So if you have a CWID and a password, you can see all of these dashboards on our Infonet right now. We wanted to be transparent about our data collection. We wanted people to understand how documentation is improving over time. And we wanted people to be able to see how we sort of validate some of the data and how closely it matches or doesn't match. One of the things that we found is that, and we did some initial analyses of this, and it didn't, sometimes you do the data analysis and it doesn't help you identify what the intervention is going to be. But one of the things that we found was that in areas where there were more options, so where there was a lot of demographic diversity, we also saw that there was a higher risk of people selecting other instead of one of the identified race or ethnicity categories that we had in our system. And there's a lot of supposed hypotheses for why that occurs. I can share some of those now, but I think one, when you have a lot of demographic diversity in an area and you have 7 or 8 subcategories, it's hard for people to feel as though they are represented. It's also then difficult for staff with a lot of diversity to really feel like they are supported in asking questions about race and ethnicity. So we did a lot of staff training so that we could support our staff and say, if you are asking about race, ethnicity, language, this is how you can do it. This may be what the response you get, and this is kind of how you can navigate if people ask you, well, why are you asking me about my race? What are you going to do with that data? So not only are we collecting the data, but then we're trying to make sure that our data is actually valid. And then we're giving people some recommendations for its, I would say, for a principled use. I talked about already social determinants of health, and that we launched in our emergency departments. We're moving on to outpatient screening and then to inpatient screening. And this is because this underscores what I've already mentioned, that ultimately, for us, we believe that although population level data is incredibly important in advancing system level interventions, when we are looking at individual patient level risk, we need to assess individual patient level risk. And when we're doing data analyses, we're doing retrospective analyses to identify gaps in care, we want to be using patient level data. So we did a lot of race and ethnicity data collection, and I'm going to show you how we use that in one slide. We're now doing a lot of social determinants of health data collection of our patients so that we can identify where are areas that we need to be either investing in, where are areas where we can connect our patients better, how can we really leverage and mitigate some of the gaps in care that we see from the social drivers of health. So that's collection of data. Now I'm going to talk to you just a little bit about how we think about the use of that data, how we think about measurement of health equity. So we did a fair 1 year of work in looking at CAUTI, which is a catheter-related urinary tract infection. And we wanted to say, as an organization, our goal is to minimize and drive to zero all inpatient infections. So we know that that is part of our all healthcare-related infections, I should say. So we know that these are complications of admission to a healthcare system. And our whole entire approach is to drive those to zero. But, so we know there's organizational initiatives underway. But our question was, well, are we seeing gaps, racial or ethnic differences, socioeconomic status differences? Are we seeing differences in the way that that is being not implemented, but in the outcomes that we're seeing? So do we see gaps in care? So we took about a year to be able to create not only a process, or like an overview of the process, but we're writing up a paper right now actually about all of that work because it was so intense. And I'm going to talk to you a little bit about why it took so long. Well, the first is that I said CAUTI, and I already jumped the gun on this first question, which is, what measure are we selecting? Is it a disparity sensitive measure to begin with? And there's a whole host of disparity sensitive measures. NQF published, I don't know, it's something like 80 to 100 of them that you can look at that are disparity sensitive. So whether or not it's screening, it's colorectal cancer screening, or it's access to a specific pediatric surgery, there is existing literature that says these are ones that you should look at first. Well, we also said, well, we're, as a healthcare system, we're already doing a ton of work for quality initiatives. Wouldn't it be good if we identified, are there just gaps in some of the quality initiatives that we have? So that's in measure selection. The question that you ask is, well, what can we learn about the potential disparity? Is it something that's we are going to intervene on? Is there organizational buy-in to it? And that's, so, you know, CAUTI, CLABSI, central line infections, there's a lot of hospital quality metrics that we said, well, we want to start there. For us, this is where we want to say this is a disparity sensitive measure. The question second, and this is where a lot of the time was spent, was what's the data look like, and do we have all of it? I don't know how many people came to me in the very beginning when we started the Dalio Center to say, we don't have great race and ethnicity data. So I've been trying to do retrospective analyses, and I have 40% of the patients are other or declined. So that's actually why we spent the first year improving some of the data first, is because we got stuck at this second point, which was, do we have reasonable data for our cohort? And in this case, we did. We said, okay, so we want to focus on CAUTI. We have a reasonable data source. These are inpatients in our hospital, so we can look at what the catheter related days are, what the infection rate was, and then other comorbid conditions to assess risk. So the data quality was actually pretty good. So the first pass of the data is a raw analysis. So we just took the data and disaggregated it. You choose whatever you're looking for in terms of your disparity, and we were looking at racial and ethnic gaps in care. We were also looking at payer-related gaps in care. We were looking at language, if that was a potential gap in care. And we just did a raw disaggregation. So took CAUTI and you just split the numbers down. And that's an important first analysis. It identifies, are there large-scale gaps that we need to be concerned about? And it's easier. So this, in terms of a rough analysis, can give you directionally where you need to go next. If you don't pick up anything here, if the data is completely neutral, then you probably don't need to do many of the subsequent steps. But for many healthcare systems, they stopped here. And they said, okay, we just disaggregate the data and we see if there's a potential gap. Well, we wanted to take it to that next step and say, well, we know race is a proxy indicator. Race is important to us in the Dalio Center because racism is is a massive driver of all of the social determinants of health. So we want to be able to have something modifiable. So if we say that race is a potential factor, why? Is it because of underlying comorbid condition? Or if after we have adjusted for everything that is a reasonable adjustment, so something that has a biological basis, so an adjustment of a comorbid condition that is in the literature identified as a risk, after we address all of those, well, then we're left with the potential for bias in the system. And that's something that intervention is very different than modifying hypertension. So that was what we said, well, we want to do that next analysis. And that's what spent the next 8 months of time on doing that analysis. It was to evaluate what are the contributing factors. So for CAUTI, we researched the literature to say, well, what are the risk factors that people have cited that make biological sense? So is it diabetes? Is it chronic renal insufficiency? Is it, we use the Charleston Comorbidity Index, so it's an assessment of severity of illness. And we adjusted our data based on this evaluation of underlying comorbid conditions. And then we said, is the data, do we still have gaps in care? And I think this is where that first pass analysis is really important as directional. But then it's identifying, well, what are some of the modifiable or intervenable risks? So I can tell you just, I didn't bring the data because we're hopefully publishing it, but we didn't find any gaps after we did this risk assessment. I think some of this, and as I said, this is time delimited work, because the goal of the organization is to say that the goal should be 0. We should have 0 CAUTIs. We should have 0 CLABSIs. So we have a small window of time as we're driving that number to 0 to be able to even disaggregate the data. So when I talked about data overview, we had to use a year of data as a roll-in, because we didn't have a high enough N to be able to disaggregate the data by race, ethnicity, language, payer, and all of the other things that we did. So as we started to do this work, we said, well, even if the whole organization ends up driving down to 0, we want to make sure that as we get there, we're doing that equitably. So at the end of all of our assessment, we didn't find any intervenable gaps, but the process that we ended up with is what we're actually now publishing. This process of that first disaggregation of data, the process of then adding in each individual risk, and then also doing the hard work to make sure that as we're adding them all in, so I think we ended up with like 6 different models. We added them one at a time, and we ended up with a fully saturated model with all 6 adjustment factors, which again, were clinically relevant. And I think that for us is the hard work at being able to use this data the right way, or I should say quote unquote right way, one way, but takes a lot of time. So this was about a year of a lot of really smart people trying to think about how we are assessing this data. But I think that's really where we're driving, is that if we're going to do the hard work of collecting the data, we want to make sure that as we're doing the retrospective gap analyses, they're really investing the time to identify some of the true problems. Because at the end of the day, by saying, well, patient population X versus patient population Y, there is a gap there. My job is to help figure out, well, what is intervenable? How can we close this gap? Whether or not it's with a large scale systems overhaul, or is it because we actually need to just make sure that we're translating into multiple different languages, or that our communication is a little bit different, or that we're lowering blood pressure, or that so the intervention has to be matched to the actual gap that's identified. So we spent a lot of time here. It was actually a fun process, but I don't think this I don't think we all appreciated how difficult it was going to be to do this work. I think we thought that this had been done by many others before us. And I think then when we got into some of the analysis of the data, we realized that there are other organizations in the same place that we are trying to do this same analysis to identify any potential gaps in care. These are other places where we're working now. So adult inpatient quality measures, CLABSI is its own challenge for a lot of different reasons. We get stuck in the quality, in the actual quality of the data and what's accessible. But CAUTI, CLABSI, inpatient falls, all of our inpatient quality measures are a good place for us to start to identify if there are any potential gaps in our care. We also have an existing dashboard. This one is unfortunately not widely viewable by all of you, but it's a dashboard to support the work being done to redesign our ambulatory care spaces. So this looks at a number of agreed upon measures. So things like access, both virtual and in-person access. And then all of that data is just rough cut disaggregated by race, ethnicity, language, and payer. And so we want to make sure that access to our system is equitable. Those dashboards are accessible to all of our staff at our leadership staff at our ambulatory care networks, as well as in our faculty practices at Weill Cornell and Columbia. I just previewed a really beautiful transplant equity dashboard, and I give a huge amount of credit to Demetra and her team for putting that together, again, to assess in real time, how are we doing as an organization? Are we providing equitable care? And where are places that we could do better? There's a couple of other initiatives that are underway, but I'm looking at the time and I'm almost at time, so I'm going to speed through the last couple of slides. So just to give a sense of where all this lives within the Dalio Center, we do spend a lot of time on data, but that's actually just the foundational pillar for the work of the center. The majority of our work is here in our clinical and community strategy. But as we think about each of our initiatives, we think about how we not only need to use data, but then also to implement, but then also to hold ourselves accountable. So here in our enterprise sickle cell program, we actually worked with Children's Hospital of Philadelphia and are building out a pretty extensive dashboard and Epic templates to be able to track in real time healthcare maintenance, to track in real time quality outcomes for patients enrolled in our sickle cell program. So again, it's really thinking about at the outset, what is the data that we're trying to collect and how are we going to use it? There's a number of other initiatives here, but for time, I'm just going to say that we publish an annual report, which details all of the different programs that we do. We also, our 2022 report will be out in January 2023. We support faculty research in this area. We just received our second year of letters of intent for our second year of funding. Last year, we awarded 6 grants, each about $100,000 to do health disparities research across the system. We also do some operations grants within NYP, funding things like early childhood collaboratives, mobile medical units. We have a pretty broad range of funding. And then lastly, in leadership and education, we have a couple of fellowship programs under the Dalio Center, as well as we just had our inaugural national conference on October 3rd at the Brooklyn Museum, where we talked about the impact of race and racism on health. I think hopefully some of you were able to tune in, but if not, we're going live tomorrow with the video recording of all of it. Again, all of these things will be linked from our external website. So we are at www.nyp.org/Dalio Center. It's pretty easy. Also, if you just, I think, Google me or Dalio Center, it's the first thing that comes up. We try to publish as much of this as we can, because as we're doing this, one, we don't know it all. I am very humble in saying that this is work that requires collaboration, but also, as I started with, this is work that requires transparency and really cannot be siloed. So if we're doing in our little back office, doing all these data analyses and not sharing that, I'm not the one at the bedside that's going to be implementing some of the interventions. I am at the bedside sometimes, but not as much as I used to be anymore. So this work has to be done in collaboration. And one of the reasons I love coming here to talk is because, as you can see, we spend a lot of time in data. Data was not my background. It's not where I started. I very much thought I would be probably a cardiologist doing heart failure at this point in my career. So interesting how things turn. So always very happy to think about other collaborations, or people have great ideas, or if there's different ways that you think about the use of data, we're always happy to get some feedback, as well as recommendations. So with that, I'm going to stop. I think I have 14 minutes for questions, which is wonderful. So I'm going to stop sharing. And if there's anyone that has any questions, please feel free to ask.
Wow, thank you so much for that talk. Just to streamline question asking, if you could use the Zoom functionality to raise your hand, we can go about it that way, everyone. Great, Opera, go for it.
Hi, thank you so much for your talk. It was really interesting. I was wondering how you if you could talk a little bit more about how you go about collecting data and engaging with communities that may be hesitant to share their data, while also working to kind of repair trust and build relationships with those communities.
That's an excellent question, and it's where we spent a lot of time thinking about that. So before we even launched any of the work in We Ask Because We Care, we actually had been doing a lot of work in building vaccine awareness. And I went into a lot of communities and talked to people. And I sat and I listened and I said, I'm not here for anything other than to be a resource. So it was being open. It was getting a lot of feedback. So when we launched our We Ask Because We Care initiative around race and ethnicity collection, we asked our patient and family advisory councils, we asked our patients, what do you think when we ask these questions? How do you feel when we ask this way versus that way? What's information that's important for you to know? So we really wanted it to be patient informed and patient centric. The other thing is that we have the benefit. So the Dalio Center has only been in existence for 2 years, but we are extremely close collaborators and partners with our Division of Community and Population Health up in our ambulatory care network. And there is extensive community programming and work that's been going on for decades. So we were able to really layer on to a lot of the relationships that had been built in the community for years. But I've also done, I don't know how many tours of community-based organizations. I've done tours of churches. I've gone into communities and we said, we're just here. We want to listen. And I think that is the first thing. You can't come into a specific community, whether it's Upper Manhattan or Brooklyn or Queens, and say, we have the answer. I think you can come into a community and say, we want to help, but we want to do it with you. So we did spend a lot of time on the actual language though. So we reviewed that with multiple people. We made sure that anything going that was patient facing was translated into as many languages as we could. We also then made sure it was at the correct reading level. So everything that we did, we tried to make sure that we were really thinking about whole person care. And we were open to criticism. So if someone said, I don't like that, we were like, okay, well, how can we make it better? So I think it's remaining humble. It's being honest about the history. It's not shying away from the past. It's not saying that we don't think it happened. No, it is happening today. We know that racism exists. We know that there is racial bias in our healthcare system. And it's actually why our first conference was Race, Racism, and Health. We didn't shy away from talking about racism. And that conference was kicked off by our CEO and our funder. So Ray Dalio was there with Steve Corwin, and they talked about the importance of us sharing the stage and talking about racism in the American healthcare system. So long answer to, we spent a lot of time thinking about it. We actually had a working group that met every week for a year to review all of the sort of patient-facing information that we had, our staff trainings, and we asked a lot of questions.
Thank you.
Sure.
Dr. Cantor, go for it.
Hi, Julia. Thanks so much for that. I think you started to answer this question, but I wanted to add a little bit of maybe color to that, because at AMIA last week, one of the most eye-opening sessions I attended was actually on the relationship between SDOH and the community-based organizations, and the interface between the EHR and those organizations. And it was Trenton, San Diego, San Francisco. Trenton was not very happy with their connection to the EHR, to that data, and to the organizations, and how that data was being moved around. And it seemed like the medical model we have is that, we will assess it, we'll create the right sort of codes in the record to represent these gaps. At a patient level, we will then refer, and then we will wait to get the referral back and find out, did the food insecurity or the housing insecurity, whatever, get fixed, and how's the patient doing? And that didn't really work in the real world when it came to these CBOs and the relationships, and many of these marginalized communities, not just race, but these other marginalized communities being really hesitant. So have you seen that as well here in New York City? Although I'm in Chicago right now, but is there a active technological and sort of socio-political outreach to those organizations to close the loop? And not only is it on the data collection side, but it's really on impact side. And are we making sure that we actually are able to do something?
Yes. Short answer is yes. Long answer is it's incredibly complicated. So I think there's both an IT, so infrastructure intervention, and then there's also just the people, the person to person. You got to put in the time to make sure that our community-based organizations feel supported. So on the information technology side of this, we are actually on a platform. So as you all know, I flashed this slide up. We're on Epic as our EHR, as I'm sure you all are very well aware. And what we have done over time and what we're building is an integrated model that allows us to refer patients to specific community-based organizations, and then have those community-based organizations put whatever the gap closure is in our EHR. So it goes through our third-party platform, NowPow, but then NowPow, if you're really aware of what's going on, NowPow was purchased by Unite Us. So by next year, everyone will be on, that was on NowPow will be on Unite Us. But that is a third-party referral mechanism that allows for in EHR sort of closure of the loop. Well, that's an IT fix. That's not a person-to-person fix. So you can put the referral into the system and then nothing happens to it. So then there's all of the work that you do to build out your community-based organization network and to build out referral capacity. And again, that's where I think some of the models that we have seen that have been very successful are run through our community, our Center for Community Health and Navigation. So we actually pay for community health workers that stay in the community-based organization. So they are funded by New York Presbyterian, but they stay in the CBO. And they're part of that closed loop referral system. That's been extremely successful. And in fact, we've just expanded on that. So we expanded when I was talking about our ED work on social determinants of health, we expanded our navigator program. So these are navigators that now are in our EDs that help to refer to community-based organizations. And many times referring to community-based organizations where we also have someone that we've been working with or are financially supporting, and then help to make sure that those loops get closed. So there's infrastructure IT building happening, but then there's also the infrastructure of community-based organizations that we're also building. We have existing relationships with multi-service providers like Canva, Henry Street Settlement, and we're building out programs that are customizable because of just what you said. I mean, and if you look at CMS or Joint Commission, there actually is no requirement to refer. They're making requirements to screen. And I think we feel very uncomfortable with that because I think that erodes a lot of the trust that you have with communities that have been historically marginalized and are still marginalized by saying, we're going to ask you a lot of questions, but then we're not going to do anything about it. So what we're doing, I mean, not making this a political talk. So CMS did what it did. I hope in the future, CMS brings the part about referral, and I think they will. It's just that not every healthcare system was in the same place at being able to launch full-scale screening plus referral. So
I think it'd be interesting, just sorry to interrupt, but I think that so Trenton could definitely learn something here from this, because using NowPow, you know, they were really unhappy with that connection. And so I think you've maybe there's some things we can make sure we don't make the same mistake that they made, but also, is there a way to take the lessons you just described in terms of the commitment and closing the loop and the human side of this, and make sure it doesn't get lost. So thank you, Julia, for that.
Of course. We spend a lot of time with NowPow and Unite Us, mainly because you know, Daniel Barchi, who was our, until about last week, was our Chief Information Officer at NYP. He always said something to me that I thought was very relevant, which is that the IT system, not only should it be supported, but it should be something you're not even thinking about, because it's making your work seamless. And unfortunately, a lot of the things that we're doing for closed loop navigation are not seamless. And they instead add a layer of now making sure that a community-based organization has to now be on another IT system to connect with us. Well, what's our responsibility to help make that happen? And I think that's where we say, like, not only in advocacy, working with NowPow, Unite Us to say we've got to make this simpler, but then in operational grants, in saying, listen, we're going to work with you because this is really important to our patient population. And community-based organizations don't have the same resources that we do to be able to effectuate this change. So I think this is where the healthcare system has to kind of start owning it a bit more, owning not only the implementation, but also owning some of the, owning a lot of the advocacy around it.
Thank you so much. And Adrian, we've got time for one more.
Great. Hi, Dr. Iyasere. I would just want to say, first off, thank you so much for the talk. I am part of a student group here in the Department of Justice Informatics, reading group and growing beyond just reading. And so everything that you talked about really kind of resonates with me, and I'm sure with the other students that meet and discuss this weekly, especially the technical aspects and kind of the human aspects, with the humility and knowing the systems and where it all comes from. And so I really, I've already added your talk that you'll release tomorrow to our list for things to talk about, and we'll add it to our toolkit that we're developing. So that's the first thing. My question comes to, I really liked how you were talking about capturing the lived experiences of people and patients, and especially how to do that in an accurate and complete and a nuanced way. And so I'm wondering if in the future there's a potential space for using patient contributed data to supplement, to validate, to make sure that people's identities are nuanced and accurate. And also, you know, potential for things like consumer health devices, wearables, things that lower the burden of data collection and things like that.
Absolutely. I think that, you know, so one of the spaces in which we were really allowed, let me take one step back and say, I think the best resource for all of our data is our patients. So you know, making sure that patients feel as though they can share with us, like that's our responsibility, is to build that trust. And I think when we think about like whole person care, we need to really understand not only the narrative of someone's life, but then, you know, yes, I am a hospitalist, so it's the blood pressures, it's the hemoglobin A1Cs, all of that as well, but those don't exist in a vacuum. So allowing patients to update their information, I think, is incredibly important. And I think we're moving there. So the whole open note system is now upon us, really allowing people to own their medical records, to understand what are we saying, what's your role in your own advancing your own healthcare. We also so as part of a working group around making sure that we could include preferred pronouns in the healthcare system and where that lived. and it's just a small step, and it's a first start of people being able to say, this is how I want to be addressed. This is how I want to interact with the healthcare system. And one of the ways in which I think we're hoping to have the most influence is by really asking people to fill it out themselves. So we've drafted a communication that goes out to all of our patients that says, update your information. We want you to include, and this is why we're asking. This is what we're going to do with it. You don't have to if you don't want to, but it allows people some ownership around their own data, which ultimately it's yours. Like this is your patient data. I'm really sorry. I do have to step off for a 2 o'clock meeting that I really can't be late for, but I am always happy to come back. So if there's more that people want to talk about, I can do like a 15-minute talk next time, and then we just do a lot of questions. And also we have a book club where we talk about a lot of this stuff. So if anyone wants to join our book club, let me know and we'll put you on our list. It was really great to talk. As I said, please send me questions if you have them and I didn't get to them. And then also very happy to come back in the future. Have a great
Thank you so
afternoon,
much.
Thank you so much.
Bye.
All right. Thank you, everyone. Have a great rest of your week.